This presentation was recorded at the 2015 ANZICS ACCCN Annual Scientific Meeting.
The good news is I'm not going to be terribly long, and I'm not particularly technical, and I'm not particularly smart with stats. What I want to present to you is some interest I've had in what intensive care costs, and I should say this has come out of a survey we did a year ago, and I'm still really playing with what the data is and how to present it. So bear with me because it's all quite not formed in the way that I'd like to present it. I should point out that New Zealand has a very heroic person on their $5 note, and the Australians have the Queen, which I think you make that what you want. Right, so the aim of this study that I'm trying to do, a series of studies, is to measure the cost of intensive care and ask questions like what's the average cost per patient, what's it cost the country, what makes up the cost, and what's the variation. Now it's interesting trying to compare this with overseas places because hardly anybody else can do this at a national level, and it's either done by disease, like what is ventilation costs, what are sick patients cost with that. And the UK have done a bit of this, but again I think we're in a unique position of having a registry that does pretty much know where all the ICUs are and can survey them. So what we've done, we have a survey we do every year of all the ICUs, and so we added some cost questions into last year's survey. And I should point out this is a voluntary survey that we get people to do out of the goodness of their heart. It's not a study that you decide to enrol in and complete all the data with. And it's modelled on the UK cost block methodology, which divides all your costs into bits. And so there's staff costs, consumables and clinical support. And what the UK guys found was the non-clinical stuff didn't really vary much, was pretty hard to measure, so they sort of ignored that in terms of the data collection. It doesn't contribute a lot. So we took the survey from a year ago, and it's now an online survey, and the survey asks about how many beds you've got, how many admissions you had, what your activity is, and a bit about staffing. And this is what it looks like online. This is the Wellington one that I'm trying to fill in for this year, and you can see there's various tabs across the top, and one of them is cost. And the questions we asked were, what was the total planned budget, which was a completely useless question, we've worked out. But what we really did get was, remember, what was the actual money you spent on your ICU in that financial year. And then we asked people to tell us about their senior medical staff. And for each of these items, we asked, was it included in your budget, and how much was it? Now, predictably, nobody filled all of it in, because it's actually either quite hard to find some of this information, and it's sometimes hard to tell whether it's in your budget or not, surprisingly. So we know there are 205 units in Australia and New Zealand that we were able to survey. There's another 2 that had started up in that year, so they didn't get surveyed. We got responses for the survey back from 81% of them, and 95 of them provided some cost data, but the cost data wasn't complete, hence making this quite complicated to analyse. I should say, for anyone that didn't put a survey in, Jane rang them up and said, how many beds have you got? So we do know exactly how many beds there are across the 2 countries, which I'll come to later. Now, in terms of responses, the interesting part here was the private units had the least response to the survey, and the tertiary and rural people had quite a good response in terms of the cost data. And overall, we had about 50% of the 2 countries provided cost data. Now, we're a bit about calculations, just I'll come to that later. So to calculate a cost per bed, we took the total money you spent running your ICU divided by the number of beds. For the cost per patient day, it was the total cost divided by the total number of patient days. And the total cost for the countries, what we did was we took the median or average cost of a bed and multiplied that by the number of beds. Now again, time doesn't permit me to go into all the detail of this, but that's the sort of basic gist of it. So first up, what does it cost per bed? Now again, not all the units told us how many beds they had, or actually they didn't tell us how many beds, gave us enough information to do the cost bit, but here it is broken down by unit classification. And the 2 important bits really are that for most units, the median and the mean costs were about the same, except for the metropolitans. But the staggering, not staggering, the slightly surprising thing is there's quite a variation in the costs of a bed depending on the size of your unit. Maybe that's not too surprising, which we'll come to. But overall, for Australia and for New Zealand, now again, they're separate things because they've got separate dollars, the New Zealand peso and the Australian dollar. It's about $800,000 to run a bed space for 1 year. So every time you think about, wouldn't it be nice if we had another 1 or 2 beds in your unit, just think of the $1.6 million you've got to find to fund that. However, this was a start to look at what does it cost. Trying to break it down into a cost per patient day is more important because a bed might be used, it might not be used, it might depend on the occupancy of the bed. So people tell us how many patient days they have. We divide that into the total cost. And again, here's the median cost per patient day for the different types of units. And again, you can see the tertiaries are much more expensive at $4,000, and the metros intermediate and the private and rural are a bit cheaper. And overall for Australia, it's about $3,000 per patient per day, which is quite a lot more than what it costs if you're sitting in a hospital bed. Now, I haven't put the interquartile ranges or the variance in the interests of time. But what I did wonder was, is this affected by how big your unit is? So again, not being particularly statistically minded, I thought a visual graph might help. And I was never quite sure how this was going to look in a big room. But what I've done is taken the type of unit and the cost per day for each of those units and the number of beds. And there's a few things that are obvious. There's a huge range in that cost per patient day. From down the bottom, someone's running at $1,000 per patient day, someone else is running at $6,000 per patient day. It's a huge, cutting out the sort of top and bottom ones, a fourfold difference in what some units cost. Secondly, if you get more beds, does that make you more expensive, less expensive, more efficient? And again, the tertiary units are the ones with the bigger number of beds, and there probably is some statistical way of working out whether it's whether they are more cheaper or not, but that's what it looks like at the moment. But the variation's quite noticeable. And if in New Zealand there's a lot less units, and I've deliberately not told you whether they're metropolitan or rural in the interest of trying to keep some confidentiality, but again, it's a slightly different picture where as you get bigger in size, the cost per patient day appears to go up in a linear fashion, but you don't see that in the Australian data. So why is there such a variation? Well, the next question was, what goes into your budget? So of the 95 units, a number of them could tell us whether things were in their budget or not. And I've circled the surprising one. So 64% of the units, the medical costs were in the ICU budget. For 36% of the ones that replied, it wasn't in the ICU budget. Now, most of these are the privates or the regional rural ones where the staffing model isn't that you employ doctors in the unit, but there's still some metropolitan ones where the medical costs aren't in there. All the nursing costs are always in the ICU budget. I really didn't expect any difference, but nice to confirm that. But everything else is a bit variable. Some have laboratory costs, some don't, some have transfusion costs, and some don't. So quite a wide variation there. But I'll come back to the medical costs bit in a minute. So maybe whether the stuff's in your budget or not affects what your cost per patient day is. So we could add up or count how many of those items were in your budget and how many weren't. And when you plot that across the bottom against the cost per patient day up the side, you get this sort of scattergun, shotgun looking thing, which suggests that there isn't any correlation between the absolute number of items in your budget and the total cost per patient day. But in fact, I'll explain why that's bleedingly obvious now. And that's when you look at what the staffing costs are. So before doing this, the UK people had identified that the staffing costs make up 80% or 70 to 80% of the cost of running your unit. Now remember that I said that the median cost is $3,000 per patient day. Some of the units told us exactly what their nursing costs were, and the median for that was $2,000 per patient day. So that's 66% of your costs just in the nurses. If you included the medical staffing, you add another $500, so you've now got $2,500 out of your $3,000 staffing costs, so it doesn't matter whether your laboratory, radiology or drug costs are in there or not, because they possibly won't influence the cost per patient day much. The interesting thing here is the variation, so I've got medians and interquartile ranges, for nursing is pretty tight. So the nursing costs across all the units are pretty similar, and yet the medical costs vary quite a bit. And I suspect that's because the medical model across the units varies quite a lot, and the nursing model is probably pretty standard. Now, I haven't divided this into classifications. Again, that's more work to present, but I suspect there'll be a difference between the tertiaries and the other units there. Now, if we plot that against the number of beds, you can see that as the units get bigger, maybe there's a slight decrease in the staff costs per patient day, maybe not. Again, I need to get someone to do some stats to work out whether that's significant or not, but it suggests that there's, again, a bit of variation, but it's not, the size isn't too important. Now, at this point, I got quite confused about how to predict what the total cost was, because some units had medical costs and some didn't. And about this time, I got a phone call to say there's a bunch of stats students from Victoria University looking for a project. Do you have anything in mind? And it's interesting, this was third year people doing a stats degree, and they wanted some dirty data to play with. So I said, I've got just the thing for you. And said, can you tell me whether the inclusion or exclusion of medical costs influences what the total cost was? And they went away and came back and used a whole lot of stats I didn't understand because they weren't medical stats, which I thought was quite interesting actually. I had to do quite a bit of homework to catch up on it. But what they did tell me was the variation in costs is mostly explained by the unit classification without me worrying whether the medical costs were in the budget or not in the budget. And that's quite helpful because now I can use that to predict what the total cost is. And we all understand why the medical costs might vary. Sometimes they're in the budget, sometimes they're not. You can have different, some have specialists, some have registrars and some don't. Anyway, from this I was able to have a bit of a punt at what the total cost is. So we take the average cost per bed and we know exactly how many beds there are in all the units and we multiply it out and it looks like this. So we know there are 61 private units, they've got 628 beds, and that the median cost was $500,000 per bed, so the total cost is that. And when you add it all up, you get a number at the bottom that's $1.6 billion being spent on intensive care in Australia in 13-14. Now, I don't know much about how you extrapolate from a 50% sample to a 100% sample for this, so I've got no idea about confidence intervals, but it's sort of a rough idea from there. And we can do the same for New Zealand. And what you really want to know is what does that mean in terms of health expenditure. So for New Zealand it's $213 million, and there's some good websites with information, and so in Australia that's 1.2% of all health expenditure, primary, secondary, public and private. For New Zealand it's a bit less, it's 1.3% of the public health expenditure in Australia, and it's 3.4% of all the hospital expenditure in Australia and 3.7% in New Zealand. So that's for a small number of patients, that's quite a big amount of money, which is something we all knew. Interestingly, when you do it per patient, as in a population thing, it's $77 per person in Australia, whether they go to hospital or not, and $47 in New Zealand. The reason for that might not be intuitively obvious, but if I go back here, in Australia there are 628 private ICU beds out of 2,000, so that's a bit less than that's 30% of all your beds are in the private sector. In New Zealand that's about 8%. So although we might spend the same amount on the patients, you've got a much bigger private sector, so you provide a much more service to the population than New Zealand does, and that's what Medicare does, which we don't have in New Zealand. You can, now these are New Zealand dollars and Australian dollars, there is a way to compare dollars between countries, and it's called the purchase power parity. and this is probably the best way to describe this is the McDonald's Big Mac index type thing. So the amount of dollars you spend in your country depends on what it costs to produce the goods in your country and what the other expenses are. And the OECD people have a way of working out, if you go and buy a standard supermarket trolley full of stuff in your supermarket and work out what that cost is, compare that to that same trolley in New Zealand or the States or somewhere else, and then you can compare the dollar value and come up with some index called the PPP, which is this thing down here. So, and then you adjust for that, and you end up with this number that's got no value, but you can then compare that back to the US dollars. So this is not about an exchange rate comparison to US dollars, but what your economy is worth and how that compares. Anyway, that brings the numbers down a bit, but what it shows us is that doing that, the cost per bed in Australia and New Zealand is pretty much the same. The cost per patient day is very similar. The medical costs are more expensive in New Zealand, and again I speculate that's because we don't have much private practice. So if you're a tertiary hospital doctor, the only place you get to work is the tertiary hospital. In Australia you can go and work in a private hospital as well, which subsidises some of the cost. And the nursing costs are, again, more expensive in Australia than New Zealand, and I don't know again, there's not statistical numbers to show that. But again, because of the private sector and the larger number of patients receiving intensive care, the cost per capita in Australia is higher, although the costs per patient are probably about the same. So in conclusion, in this sort of, I guess, first look at this sort of stuff, there's quite a considerable variation in what goes into into units budgets, much more than I expected. There's quite large variations in the total cost of providing intensive care for a unit. A lot of these differences can be explained by the classification of the unit, although I haven't shown that here. The nursing costs are much more even, and the medical costs vary quite a lot, which makes it a little more complicated to try and compare units, because you're going to have to account for that. So if I just put up like a funnel plot or a caterpillar plot of the cost, I'm not sure that's valid to do, because it does depend on what your medical model might be. So that might be a whole lot of different caterpillar plots to try and work out who's more expensive there. And the things I want you to go away with are that the average cost per patient day is $3,000, which is actually less than I thought there. For the tertiaries, it's probably up near $4,000. That the cost of a bed's $800,000, which is a sobering thing to bear in mind, and that intensive care is a significant health cost. Thank you very much. Questions?
Thanks very much, Peter. Has anyone got a question?
I've got one.
Go, David.
Didn't you look at this 10 years ago? Are we more expensive or less expensive?
Yes, I looked at it 10 years ago, and no, I haven't looked at it to compare, but it's not a lot more expensive. I think it was about $2,500 per patient day 10 years ago. That's the next bit of work to do.
Oh.
Hi there, Peter Harrigan from Newcastle. I noticed on the private analysis that the private costs per bed seem to be much lower, but their cost per day was much higher. Am I right in saying that that's probably because the private ICU seem to have a lot of beds that are sitting around not being used, and when they do get used, a lot of people come and spend their money there? The implication is that the private ICU's got a lot of capital expenditure which is not being exploited, and that becomes burdensome on the whole system, given that we'll end up paying for it in the later term.
I guess it's all speculation, but given that staffing costs are really 85% of your budget, I suspect, certainly my experience of small private ICUs, is you've got to have a lot of staff hanging around just in case a patient might turn up, or you've got them on Monday to Friday but not Saturday and Sunday, so the staff cost is not supported as well by the patient workload. But again, it's just speculation.
Peter, are you able to look at the influence of the percentage of acutes? Because we have a high acute admission number, and we've used that to justify with our managers that we are a bit more expensive and that our bed occupancy can't be all that high. we have a short length of stay and people are acute, and obviously you have to discharge someone and empty the bed out before you can fill it up, so that when you count it on a census thing you won't always have a full bed, and that acutes come 24 hours a day, which affects your staffing model a fair bit. So I wondered whether that would explain differences in the cost per bed.
I think what this has shown me is handing out a complicated survey on a voluntary basis doesn't get you good data, because there's quite a bit of missing data in that, and really to do this you need complete data. So I suspect what we need to do is actually, just to take this back a step, what we're doing for this financial year is getting rid of all the underneath questions and just asking what's the total cost of your ICU and forgetting about the component bit, just to make the survey simpler. But to do this properly, to allow to answer those questions, we're going to have a group of motivated units who are happy to fill in all the details so that we have a complete data set. And then we can start seeing whether your occupancy or acutes or elective or stuff changes stuff.
Peter, could you improve your compliance with that information by putting it into the core database? Would that be something?
Well,
that would
it's
cause
really
that
the survey we do rather than it is one of the core databases, if you like. That's the annual survey that it goes in rather than the patient level data. Is it? Jeff?
Thanks very much, Peter. How do you get around the problem that I could have a very inefficient ICU that only ever admitted 18 patients to the ICU? They stayed in 18 beds for a whole year because it was so useless at discharging them. So how do you pull out from this data the efficiency with which you use your resources per patient treatment of a specific condition?
Well, that's a very simple question to answer, Jeff. You define what efficiency is and I'll tell you what the number is. I think the interesting stuff, if we could get some good data, would be looking at things like length of stay and cost, staffing models and cost, outpatient outcomes and cost. Anything's possible, but the problem at the moment is the data's a bit too dirty to do much with it.
Thanks.